Hello, and welcome to Basics to Brilliance Haematology Podcast, the podcast series that will take your basic haematology knowledge up to a level needed to be an effective haematology registrar. We hope that the content we cover here will help you prepare for the dreaded Haematology FRC Path Part 1 examination. But most importantly, we hope that this series fills you with excitement for the fantastic, dynamic and highly rewarding specialty of haematology. My name is Dr. Anharid Everden, Haematology ST5 Registrar in the Southwest Deanery.
And my name is Dr. Syed Haider Jaffrey, Haematology SHO and aspiring haematologist.
And let's get started on today's topic.
From basics
to brilliance. Hi Haider, it's lovely to see you.
Hi Harry, yeah, likewise.
Yeah.
Glad to be back on here.
Yeah. Haider, for all of those at home who are asking about David at the BSH, Haider is another very important member of our team who, without Haider, our podcast does not exist. He's done all of the editing behind the scenes, exactly, and all of the technical stuff, which honestly I haven't got a clue about. So we're very grateful to you, Haider, and it's really nice to see you again on an actual podcast.
Oh, it's my pleasure. Yeah, it's great to see you as well.
Yeah.
We'll try and get David in for like a triple threat podcast sometime.
That would be good. Yeah, nice. That would be good. Maybe the HPLC one. Maybe I'll subject you both to in-depth HPLC knowledge.
That sounds exciting.
But today I thought we'd do another clotting one because it was lovely to meet so many of you at home at the BSH ASM this year. And it sounds like people have found the clotting series really useful for part 1 and for life. And that makes us really happy, doesn't it, Haider?
Yeah, I mean, so many people at work, because I'm in Leeds at the moment, they keep coming up to me saying, well, this podcast is amazing. Harry and David are so good. And especially the clotting ones as well.
Yeah.
They're finding it really useful.
Exactly. It's really nice that people are finding it useful. So thank you to everyone at home who is listening. We really, really appreciate your support. And yeah, we're just doing this project because we want to help people and make learning haematology easier. So
and fun.
Exactly, and fun. So we're going to carry on with our coagulation series alongside the red cell series in the hope to cover more of the course more quickly. So I know we said that we had finished haemophilia as a series, but I forgot that we hadn't done Haemophilia C, and then I had another case of it crop up at work, and I was like, oh, we should probably do a podcast on this. So Haemophilia C is what we're doing today, Haider. I thought we'd start with a case.
Yeah, let's do it.
Okay, so real life case. I was called as the Haem Reg on call, and a patient needs a NOF repair. Apparently she has a history of factor 11 deficiency, according to the patient. What do they need to do before they take this patient to theatre? And are there particular things that you want to know from what I've given you so far?
So after listening extensively to all the haemophilia and clotting ones, I'll try not to muck this up. Mm-hmm. So you need a bleeding history, which is the first most important thing.
Yeah.
To ask the patient whether there have been any major bleeding incidents with any procedures in the past.
Okay.
Normal clotting, you would want to do a mixing study. If the mixing study corrects, then there is hold on. A clotting and an APTT. So your APTT will be increased.
So a prolonged APTT. Yeah, very good.
And then if the APTT is then increased or prolonged, then you would do a mixing study and see if it corrects or not.
Yeah.
And you can do a factor assay after that.
Okay. Yeah, very good. So we're going to want some lab tests to find out what the factor 11 level is. And I'm really glad that you started with the history because of all of the bleeding disorders that we've covered so far, this is particularly the most important one in which a history is absolutely vital. And the reason is because it's actually quite a variable disease in nature. And we probably end up over-treating a lot of haemophilia C. Okay, so that's a really good start. Let's park that and we'll come back to it at the end when we've talked more about haemophilia C and we can apply our knowledge. So what do you know about haemophilia C?
I believe when you said Haemophilia C on the group, I said Haemophilia what now? Um, I've not. I'm sure I've read about it in when I was studying in uni, but
Hmm.
we don't. I've not personally seen any cases of Haemophilia C.
Okay.
Uh, so what I know from my brief reading was factor 11 deficiency,
Yeah.
um, and it's not severe.
Hmm.
So it's not those deep joint bleeds and
Okay.
high risk of kind of intracranial hemorrhages.
Hmm.
And it's rare.
Hmm.
That's
Okay.
basically where my knowledge ends.
Okay, brilliant. So you're right. It's a factor 11 deficiency. So haemophilia C is a factor 11 deficiency. It is not X-linked like A and B. Okay, so the gene for factor 11 is not found on the X chromosome. So it's actually inherited in an autosomal recessive manner. Okay, so this patient is a female, which normally,
Hmm.
if you were given a female case of somebody who you're suspecting some type of haemophilia, you'd think, well, bit suspicious unless she's a carrier and happens to have lots of, random inactivation of the working X chromosome through lionization. I'd be a bit suspect that she's got any significant bleeding problem as a female. But in this case, in haemophilia C, it's autosomal recessive. Okay. So that's the first thing to say. And then let's just recap the kind of function of factor 11. Why is factor 11 important? You correctly identified that it would prolong the APTT. Why is that?
It's the second step in the extrinsic pathway.
Very good. Yeah. So you've got 12 at the beginning, which is your
Sorry,
contact.
intrinsic. Second step in
Intrinsic,
the
sorry.
intrinsic
Yeah,
pathway.
yeah. So you've got your factor 12 and then 12 goes to 11. Yeah, good. So it's an important clotting factor in your intrinsic pathway. And there's actually an additional function of factor 11 that you wouldn't necessarily know about, which is that it's got an antifibrinolytic role. So it activates TAFI, which is your thrombin activatable fibrinolysis inhibitor. And it therefore inhibits fibrinolysis, and so it helps to stabilize clots once they are formed, is essentially how I think of it. TAFI works by inhibiting fibrinolysis by removing these lysine residues from fibrin and then preventing the plasminogen, which had a super short half-life in the blood. I don't know if you remember. And so plasminogen, when it binds to clots and things and binds to fibrin, it's stabilized and has a longer half-life to then get converted into plasmin. And so essentially that's how TAFI works to
Okay.
reduce fibrinolysis. So it's got a twofold role. It's got both the intrinsic pathway and also an antifibrinolytic role as well. And
Hmm.
you said we'd then go on to assay the factor levels. Do you have any ballpark ideas in your head as to what might diagnose a haemophilia C? Mean question, because I wouldn't have even heard of haemophilia C at your stage.
Hmm. No. I
That's
have no
fine.
idea.
So, I mean, normal levels are between 70 and 100 IU per DL. Now, I know we're encouraged to use IU per ML, but I still prefer DL because I can think about it as a percentage in my head.
Yeah,
So,
yeah.
like a level of 100, I just think about it as like 100%. So, essentially, a level of between 15 and 50% IU per DL, or percent in your head, is somebody who's partially deficient in factor 11. Okay. So that's not convincing, but could be an explanation for somebody who has a bleeding phenotype. And we say anything less than, well, it depends where you read, but anywhere between 15 and anything less than 15 and 20%, somewhere around there. Once you're less than 15%, we would say that's severely deficient. Okay. So we say partially deficient is 15 to 50%, and then severely deficient is less than 15%. So it's
Hmm.
a much different range compared to that of our severe haemophilia A and B, for example, where we're talking less than 1%, or 1 IU per DL.
Is the 50 to 70% range, is that not clinically significant usually?
15 to 50.
No, no. So below 15%
Yeah,
is severe,
yeah,
15 to 50 is mild.
yeah.
The 50 to 70, then I'm thinking
Yeah, I don't
if we
know. I
do all
guess
these
it's a
tests,
grey
yeah.
zone. Yeah,
Mm, okay.
I certainly wouldn't be hanging any significant weight on it, or at least
Mhm,
I'd be wanting to rule out other bleeding disorders first before saying that someone's
mhm.
bleeding history would be due to that.
Okay.
So You might think, well, who cares? This is quite a rare condition. I've not heard of it before I started heme training. You've not heard of it before you've started heme training. Like, why do we really care? But actually, it's quite common in the Ashkenazi Jew population, in which it's one of the most common genetic disorders of this population. So, a partial deficiency in Ashkenazi, I'm sorry if I'm completely hashing the pronunciation of that, Jews is 8% of the population. And what I found really interesting when I was reading about it is that it's actually 7% of bleeding disorder patients in the UK on the UK
Mm.
HDCO database, which actually makes it more common than the number of patients with haemophilia B.
Oh,
I know, which actually does correlate with what I've seen clinically, because I've seen 2 cases of haemophilia C, and I've not seen, to my knowledge, I think I've seen maybe one haemophilia B case, and I'm ST6. So, like, it's one of these things that you haven't heard that much about and doesn't seem that important, but you're probably more likely to encounter it than a haemophilia B in your career. I wanted to
okay.
highlight that. Yeah, 7% of
I mean,
bleeding.
that's a very fair point.
Mm. Okay, so let's talk about the presenting complaint then, because the number one thing that you asked for was the history, which is a brilliant place to start and always the most important place to start. And probably, sadly, you'll find that the referring team have not taken a bleeding history. Uh,
Mm.
so it's extremely variable in haemophilia C. It doesn't even correlate in families. So if one family member has one type of bleeding history, it doesn't necessarily mean that the next family member will have the same bleeding history. So really weird. And 65% of patients are actually asymptomatic with haemophilia C. So as you said, it's less severe, and I would agree, it is. It's very rare to have spontaneous bleeding. And therefore, if you've got a patient with a significant bleeding history, as we were sort of talking about earlier, I would be worried about other conditions that we've missed just because I got a slightly low factor 11 level back, and I'd keep looking to exclude
Mm.
other things. Hematuria and menorrhagia can be a feature. And I think the key thing to know with haemophilia C is that the main way in which you're going to encounter it is they're going to get mild bleeding after surgery or injury. So it's very much a condition where you can get bleeding. It's usually not life-threatening, and it's in response to an insult. So an injury or surgery, something like that. These are not your patients, as you say, that are going to get spontaneous deep joint bleeds, deep muscle bleeds, or joint bleeds. It's a different phenotype of bleeding, even though it's a clotting factor deficiency. And if you've got less than 15%, then you can end up with quite excessive post-op bleeding. So the absolute number one question with any patient that you are referred with factor 11 deficiency is, do they bleed? Okay, is there a history of bleeding? Have they had a major hemostatic challenge, and what happened? And I think that is going to really, really guide your management more than anything else, more than levels with a patient with haemophilia C, which is unusual. In particular, areas of surgery where there are higher rates of fibrinolysis are in particular the areas that are going to cause an increased risk of bleeding. So what I mean by this is the nose. So ENT surgery can bleed quite a lot, nasal surgery, and the mouth. So
Mm.
dentists' procedures and tonsillectomies are the kind of situations in which they might get quite significant post-op bleeding. And that makes sense given that we know that factor 11 has this dual role of both being an intrinsic pathway clotting factor and also having this antifibrinolytic effect. So that is how it presents. So the next question is, and the question that I asked myself is, how can it be so variable? How can you have somebody with, let's say, 30% factor 11, and yet one person bleeds loads and the other person doesn't bleed? Like, what's going on here? There must be something else about haemophilia C that we don't understand. So, do you have any ideas about, like, why it might be so variable between different patients?
Mm. I mean, it must mean that there are more hemophilia C patients than we actually think if it's so variable.
Probably.
Um, is there, because it's autosomal recessive,
Hmm.
but is it about penetration?
Um, it's I don't know is the answer to that. I mean, I guess so.
Okay.
I guess there is variable penetrance because it doesn't carry through with the family the same bleeding phenotype. So yeah, there must be an
Mm.
element of that. But another big thing is just thinking about what factor 11 does. So factor 11 has two roles. It is bound by factor 12 when it's activated, 12A. And then
Hmm.
at the other end, at the business end, it then binds to factor 9. So, could it be that all we know in our testing is that the factor 11 level, the concentration is low? And that's done through functional testing of what affects the APTT. But could it be that you can have two kind of main types of mutation of your factor 11? You can have a mutation that affects your factor 11's binding to factor 12, and you can have a mutation that affects your factor's binding ability to factor 9. As in either end, it can be that 12 is less able to activate 11, or it could be
Hmm.
that 11 is less able to activate 9. Now, 11 being less able to activate factor 9 is obviously much more of a significant clinical problem than 12
Yeah.
not being able to activate 11. Because what do you remember about factor 12?
It's uh it's on the tissue,
So it's a
isn't it?
contact activator
Yeah.
and that then binds to 12, but factor 12 is not needed in real life. So it's needed
Mm.
to run an APTT in a lab in a test tube, but
Hmm.
factor 12 is not needed to clot in real life. Okay, so it's like a fake clotting factor almost. Like it's needed for us to run our lab test, but it's not needed to clot.
Yeah.
So
Okay.
it's your classic thing of a patient with a factor 12 deficiency will have sometimes a dramatically prolonged APTT, which looks extremely alarming, but actually they've got no bleeding. It doesn't cause any bleeding, and that's like a known thing. So like I
Hmm.
actually got a phone the other day about somebody who has a factor 12 deficiency, and I was like, don't worry about it, just carry on. I'm not interested. And it also is just a reminder that if you've got somebody who's referred to the clotting clinic with a bleeding history and they have a factor 12 deficiency, you have not found the answer. You need to keep looking.
Hmm.
So, therefore, it makes perfect sense that you could have a whole group of patients with factor 11 deficiency based on measuring using an APTT based assay, that their factor 11 is low because it's less able to bind to factor 12, which is not clinically required. And therefore, these patients don't really get a real bleeding history, even though they get a prolonged APTT and they have a deficiency of factor 11 measured as a result. As you have another population where their mutation affects their factor 11's ability to bind factor 9, and therefore their clotting cascade that is required in real life in the intrinsic pathway is not able to go ahead as well as it normally
Hmm.
would, and they have a genuine bleeding risk. And that probably explains this kind of dichotomy of some patients that have a low factor 11 level and don't bleed, and some that do. There's probably also variation in like background levels of fibrinolysis that different patients have, which we don't really understand. But the big point I want to make is that just because you have low factor 11 levels doesn't mean you're going to bleed, because you could have low factor 11 levels because your factor 11 isn't able to bind 12, rather than low factor 11 levels because it's not able to bind 9 and actually activate the clotting pathway that's needed in real life. Does that make sense?
Hmm. Yeah, it does. It
Um,
does.
and the reason why I'm labouring this point is that there are a lot of patients where we should not be replacing factor 11, and that actually we're massively increasing their clot risk, and it is associated with clotting. Replacing factor in some patients with a perfectly believable lab diagnosis of factor 11 deficiency, but actually it doesn't represent a bleeding problem in real life. So that's the key thing. So I think the problem is we don't have a good test to distinguish between these patients, and therefore we have to just rely upon the history. And so
Hmm.
when we do replace, if we do decide that someone has a bleeding history and we do want to replace factor 11 in haemophilia C, we aim for a level of about 70 rather than the usual 100. Okay.
Hmm.
And that's just to try and kind of, I guess, compensate for our underlying fear that we might cause a thrombosis, because we're not quite sure how clinically relevant their factor 11 deficiency is.
Hmm.
So yeah, so we probably, well, we definitely overtreat this population of patients is kind of one of the main take homes from today. And the key thing, therefore, with this case is, have they had a hemostatic challenge before? And that will then lead us to knowing whether we need to give something pre-theatre or not. So if they have had a hemostatic challenge and we know that they don't bleed, then we're probably okay to just manage with tranexamic acid and,
Wonder drug.
keep a close eye. Yeah, the wonder drug. Particularly useful in this setting because of its, it works within the fibrin lysis pathway as well.
Hmm.
So if they've not had a bleeding history and they've had significant hemostatic challenge, then you could be reasonably confident to not replace anything and just do tranexamic acid. If they've got a significant bleeding history, then you're going to give factor 11 concentrate, which is a pooled concentrate. It's not recombinant, so it does come with a potential viral risk. But you're going to give that to get the level up to 70. But then what about your patients where you don't have a significant bleeding history because you've got an absence of hemostatic challenge? And those are the really difficult ones because you don't know if they're going to bleed or not because they've not had that trial yet. So kind of the consensus opinion is if it's for something like a tooth extraction or something else that's considered a relatively low risk bleeding procedure, then you could just do a trial of procedure and see what happens. Okay, so give tranexamic acid, don't replace anything else, see how you go. So maybe start the TXA a couple of days before the surgery, 1 gram 3 times a day. If it's something more significant in terms of bleeding risk, like an actual operation, like the NOF repair, then, and you really can't tease apart from the history whether they've got any bleeding disorder or not, then you could consider replacement. And that would be the general kind of consensus opinion on how most people would manage a patient like that.
Okay.
Yeah.
Yeah. I guess that makes sense. It is a bit scary.
Yeah.
If you
Agreed.
have, I'm guessing you have to have a positive family history.
Well, no, not
Um,
necessarily, because it's also more recessive. So you could not have
mm,
a family history.
but then if they've not had a
It could also
major
be de
hemostatic,
novo. Mm-hmm.
yeah, if they've not had a major hemostatic challenge,
Yeah.
then the only thing that might prompt you towards even looking for factor 11
Yeah.
is going to be a prolonged APTT,
Yeah.
which not everyone
Exactly.
will get a clotting.
No, they won't. Exactly. And you would hope that, yeah, you would hope that a lot of people wouldn't get a clotting if they didn't have a
Mm.
bleeding history, and then we wouldn't be in this difficult situation.
Oh yeah,
Do
okay.
you see what I mean?
Yeah. It's
Is
like the MGUS thing. People just check for
yes,
paraprotein or light chains, and then
yeah,
yeah, gotcha.
yeah. So in terms of treatment, then there are two options. We can either use factor 11 concentrate if you've got it in stock, and as I said, that's a pooled production, so it's human derived. And the dose is 10 to 20 IU per kg. Usually that works out that we dose them at 15 IU per kg, and that will raise it by 0.2 to 0.4 IU per ml. So 20 to 40
Okay, yeah.
for 10 to 20 IU per kg. The other option is virally inactivated FFP, because that will contain some factor 11. You're going to need quite large volumes for that, but that might be all you have in your blood bank. And we say using virally inactivated because you're going to need to use quite a lot and because you're going to need recurrent doses. So it's not like giving FFP in a major hemorrhage for somebody who doesn't have a bleeding disorder, in which
Hmm.
case using non-virally inactivated is fine. If you've got a patient where you preempt that you may have to give more FFP in the future, because you're doing it for an actual known bleeding disorder, then it should really be virally inactivated. And with both, you would also give, you would give tranexamic acid for the FFP, but they actually say avoid tranexamic acid for 48 hours post factor 11 concentrate. I guess because, again, we're worried about causing a clot.
Okay, yeah, that makes sense.
And another thing to just note is that if they've got a significant cardiac history, again, you're going to want to just think about your use of factor 11 concentrate. Really double check that it's necessary and you're not over treating. So that's that. What about if we saw this patient in clinic? Are there specific things we would want to think about in their review? I don't know how much H&T clinic experience you've had so far, Hader. Probably
I've had
low.
0.
Okay.
Absolutely none.
Yeah.
I guess it depends on their age as
Mm-hmm.
well, the
Mm-hmm.
considerations or the advice that you would give them
Mm-hmm.
in terms of activities and presentation to the hospital.
Yeah. The key
Um,
thing is an alert card with
mm,
their diagnosis and their levels in. That's actually like surprisingly useful,
mm,
especially if your hospital is still working on paper notes as we are at the moment. So an alert card and adding them to the UK database for bleeding disorders.
mm,
Vaccination status, really important with anyone with a bleeding disorder. So hepatitis B in particular, you can measure their antigen, their antibody level, and you can make sure that they don't need to make sure that they are immune and that the vaccine has worked.
mm,
You test virology, so Hep B, C, HIV. Particularly, well, you want it as a baseline before they've ever had any blood products, but also after as well. And then something that's really good to do in any clinic, H&T clinic, is to make a bleeding plan. So this is making sure that the patient knows that if you've got this diagnosis, it's probably not going to cause much of an issue unless you injure yourself or you need surgery. If you need surgery, here is the contact details for the specialist nurse. Please contact us when you have a date for an operation to let us know so we can make a plan for you around your operation. And make sure you tell your consultant who wants to do any operation to let us know and to let them know about your diagnosis. And then it's about making a bleeding plan in the notes, nice and clear at the top of the letter, so that, major and minor bleeding procedures, what you would recommend for that patient that you would do. So based on what we've talked about, whether you would recommend factor concentrate or not, because that is really going to help out your colleague in the middle of the night when you're getting phoned at like 4 a.m. with a Haemophilia C patient that's bleeding and you're really not sure what to do. Or, well, I guess bleeding is easier because if they're bleeding, then you probably do want to do a bit more. But, if you've got somebody who just needs a NOF repair, like I got phoned about, those are the ones where, you want to help out your colleague and make sure you've made a bleeding plan and an op plan at the beginning of each letter. Good. Okay, and then what about in pregnancy? Because that's always a hot exam topic. Does factor 11 go up in pregnancy?
I
I'm
will
so
pass on
mean.
that
I was
one.
going to say, I'm so mean. I wouldn't know the answer to these things if I wasn't sat in front of my notes. So I've got an unfair advantage for sure. But
I have no idea. I have no idea.
so,
If I take a guess,
Hmm.
it will go down in pregnancy.
Okay, it doesn't go down. I can give you that for
Okay.
free. Many
All
things
right.
don't go down in pregnancy because
All
if you
right.
think about it, the body,
50-50 chance.
well, the body, but it's not 50-50 because the body is always ramping up for this major hemostatic challenge in pregnancy, which is delivering a baby. So
Mm.
none of your clotting factors really go down. That's why you have higher risk of clots in pregnancy because your body is
Oh
amping
yeah.
up for this major hemostatic challenge. The only things that really go down are things like your protein C, your protein S, your protein Z.
Mm.
Which is why we don't
It
test
goes
for those
up.
deficiencies. It
It
doesn't go
goes
up,
up.
it's stable. So factor 8 and von Willebrand's factor, so our two key big players in our head, haemophilia A
Mm.
and von Willebrand's disease, they both go up in pregnancy. So that's helpful.
Mm-hmm.
But your factor 9 and your factor 11 are stable in pregnancy, which is now
Oh.
quite helpful for us to remember because we've got A and von Willebrand's disease, which are like our big players. Everyone knows about them. They go up, okay? And then our B and our C that we see much less of are the ones that remain stable.
Okay.
Okay. And so it's useful in pregnancy that 8 and von Willebrand factor go up. Obviously, that's like a really helpful thing for us because it makes it easier for us to correct any levels before labour. But remember that even though they go up and they get closer to like 100, in normal physiology, they're probably closer to like 200 at the time of delivery. So even though
Mm-hmm.
in some mild haemophilia A patients in pregnancy might normalize their factor 8 levels, that's still not normal for what it should be in physiology, if that makes sense.
Yeah.
But you don't even get that in haemophilia C. So that's to be aware of, that their levels don't go up and that you therefore may end up needing to give factor 11 concentrate. So you check their levels at booking, and then you check it again in the third trimester, and then often tranexamic acid alone is sufficient to allow labour. But we would say that if you've got a low level or a bleeding phenotype at any level, then neuroaxial anesthesia is not recommended. So we tap out of spinals and epidurals quite early, I feel. Like for our type 2 von Willebrand disease, we're just like, no, can't put a needle near the spine because we can't guarantee hemostasis. And it's the same for this haemophilia C. Even with certain levels, we know that it's not very predictive of bleeding. So low levels or a bleeding phenotype, don't go near their spine with the needle, basically, which is a significant thing for women who are wanting to have, a vaginal delivery, because their options for pain relief are going to be, well, you could listen to the haemophilia and pregnancy episode, but, their options of pain relief are going to be much more limited. And that's something that they will want to think about and discuss when they're making their birth plan. And yeah, if their levels are less than 15%, then we probably do end up giving factor 11 concentrate at delivery, especially if they've got any bleeding phenotype. Okay, but again, it's going to be really, really personalised to that individual and their bleeding history and their experience so far. Good. And yeah, they are at risk of increased postpartum hemorrhage, as you might expect, especially if they're group O. I think I'm not sure why it's with group O. Group O certainly have lower levels of von Willebrand factor, so maybe it's something to do with that. So yeah, that is everything I can think of that you might need to know about haemophilia C, based on my interaction with some. Any questions, Haider?
I thought it would be a lot less than it actually was, if I'm being honest.
A lot less
So
in
I
the
thought
sense, like less
in the
prevalent.
sense of that too, less prevalent, less kind of complicated as well, because it's so variable in its presentation. It can be so easily missed. Some of the management things are simple enough, so tranexamic acid.
Yeah.
But then when it comes to things like pregnancy, it gets quite complicated. So yeah, I thought it would be a bit simpler. And
Yeah,
how do you manage
it's
haemophilia
more
C?
difficult than A and B in that your bleeding history and your levels don't correlate. Yeah, that's hard. But it's just another reinforcement that bleeding history is a really important part of hemostasis. Shall we do our 3 golden nuggets to sum up?
Yes, please. Yeah.
So number 1, haemophilia C is a factor 11 deficiency, particularly if your level is less than 15 IU per DL, and it's actually more common than haemophilia B in the UK. So it does come under the rare inherited coagulation disorders, but it's not as rare as you might think. Number 2, history is vital. If you get called about a patient with haemophilia C, your first question is going to be, do they bleed? And then number 3 is going to be avoid thrombosis. So really try not to overtreat these patients just because their numbers look and feel a bit scary. You can trial a procedure if you don't have a bleeding history, because they haven't had a hemostatic challenge, or if you are worried about bleeding, then you can treat with factor 11 concentrate or FFP. But don't jump into replacement just because the level is low.
Lovely.
Yeah. Brilliant.
That was
Short and sweet today, I think, but
7% of all hemophilias or
bleeding disorders.
Bleeding disorders, that's even bigger.
On the UK HDCO database, yeah.
So do you want to hear a fun fact?
Always. Go on.
Yeah. So vitamin K.
Right.
In my little researching trip that I took for haemophilia C, vitamin K, it's called vitamin K because it's in German. So the K stands for coagulation vitamins.
Really?
Yeah, but they spell it with a K.
Oh, I was expecting this to be a haemophilia C related fun fact.
Oh, no. I could say a random fun fact about anything. Let me just slide that in. But no, it's been a pleasure. It's been really nice being back on, and I'm sure.
Yeah, good.
I'm sure I'm not as charming as David, so everyone's gonna miss David because he's so great. Which
David hasn't gone anywhere, by the way. He's not died.
No, no. He'll be back.
He'll be back.
back.
Yeah, we've got
Yeah.
more planned. We're just trying to up the ante, especially with my impending mat leave, to get as many recordings in as possible.
Yeah, and we will.
Yeah.
I'll join in for some other ones as well. But yeah, had a great time learning about Haemophilia C.
Brilliant. And hopefully
7%
that
of all
was,
bleeding disorders.
yeah, brilliant. Okay, well, it was lovely to see you, Haider. Thanks everyone for listening at home, and we will speak to you all soon. I think David wanted us to ask everyone to send in questions to that they are too scared to ask their heme reg. And we're going to do an Ask the Heme Reg episode of answering questions that you're... I don't know why you're scared of your heme reg, though we're all a very friendly, lovely bunch. But if you are, and you have questions that you have been too scared to ask and you want to know the answer to and get to the bottom of, please do email them in. The email address is, Haider?
It's going to be in the information in the bio, but it would be BasicstoBrilliance heme at gmail.com. So it's heme with an A, HAEM.
Yeah.
Not the American.
Lovely. Well, we'll see you next time.
Thank you, Harry. Bye.
Bye. Thanks again for listening to Basics to Brilliance Haematology Podcast. If you enjoy our series, please don't forget to like, leave a review, and hit subscribe to never miss an episode. See you next time.